Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with an interesting brain case of the day. I'd like to start by stating that all of the educational content as part of this presentation has been fully de-identified in order to protect patient privacy. So this is a patient who came to us with a history of breast cancer, and she had been having headaches for quite a while. I've got 4 images for you to take a look at. The image on the top left is an axial T2 weighted image. The image on the top right is an axial FLAIR image. Image on the bottom left is an axial T1 post-contrast image. And the image on the bottom right is a coronal T1 post-contrast fat-saturated image. So take just a couple moments to look at these images and try to figure out what you think is going on. Okay, 2 questions for you. First off, what's the diagnosis? And then the second question is, what other malignancies might she be at risk for? Alright, let's take a look at the imaging. First up, our axial T2 weighted image, and what should be pretty apparent is we're dealing with a right cerebellar mass, as denoted here by the yellow arrow. Now if you look at this really takes up the majority of that right cerebellar hemisphere. It's very diffuse. And it's got bright signal intensity. It's heterogeneous, but certainly it's bright, especially when you compare it to the remainder of the left cerebellum and the brainstem that we see on this image here. And this signal hyperintensity has a bit of a pattern to it. You might describe it as perhaps striated, corduroy in appearance. Some people like to refer to it as a tigroid pattern, but it has this wavy gyroform look to it. And you can see that it's a little bit T2 dark in some areas, but predominantly this is a T2 bright signal intensity mass that we're dealing with. When we look at the FLAIR imaging, it's still mildly hyperintense, certainly compared to the rest of the brain that we're looking at. And it's a bit heterogeneous. You can see that there may be even some CSF signal intensity cystic areas. They sort of drop out in signal intensity that are more along the medial margin of this cerebellar mass. And if you look carefully, you see that it's engaging the fourth ventricle with just a little bit of mass effect. So obviously you want to look and make sure there's no hydrocephalus anytime you're dealing with a posterior fossa mass that's exerting mass effect upon the fourth ventricle. Anytime we're dealing with something that looks like a brain tumor, it's important to give contrast. And in this case, it only has very minimal, kind of subtle, wispy contrast enhancement. You can see the yellow arrows are pointing at some linear areas of contrast enhancement that are associated with the mass. And so when you see that kind of curvilinear enhancement, you might wonder, are we dealing with leptomeningeal enhancement? Is this something that we're seeing engorged vessels associated with it? Those are questions that are sometimes difficult to tease out, and it's worth looking at the post-contrast imaging in multiple planes to try to get a better sense of what's going on. But in general, we can say that the degree of enhancement of this mass is very, very poor, and really it's pretty similar to the background brain parenchyma, maybe even lower in terms of its signal intensity, so therefore hypo-enhancing, although there are definitely areas of that curvilinear enhancement that are associated with. And you can see as we take a look on the coronal T1 post-contrast, we like this sequence because it's performed a few minutes after that initial axial, so it sort of gives things that are slowly enhancing more time to wash in with contrast. And as we can see, it really is a poorly enhancing mass, but we have these very kind of curvilinear, vascular appearing areas of contrast enhancement that are associated with the periphery of this mass. So when you put that all together, it's an essentially non-enhancing mass with maybe some hypervascularity at its periphery. So what's the diagnosis here? This is a patient that has a dysplastic cerebellar gangliocytoma, which is also known as Lermite-Duclos, if you like to name things after people, but I wouldn't advise it. And this is a benign cerebellar lesion, and it's of uncertain etiology. It really hasn't been definitively defined whether or not we're dealing with something that's neoplastic, in terms of it being a neoplasm. It certainly is a benign one if it is neoplastic, or are we dealing with something that's hamartomatous? It sort of has features of both. But from a malignancy standpoint, this is a benign lesion. But despite the fact that it's benign, it certainly can exert mass effect. And we have to worry about things like tonsillar herniation, upward transtentorial herniation, and obstructive hydrocephalus, depending on how big it is and what it's exerting mass effect on. But there are some important structures in the posterior fossa, and it's a small space, so anything that takes up real estate can have bad consequences for the patient, even if it's a benign process. One of the important things to take home is that most patients with dysplastic cerebellar gangliocytoma probably have multiple hamartoma syndrome, or MHAM, or if you like to name things after people, Cowden syndrome. So what is MHAM? Well, this is a syndrome that's characterized, as the name would imply, by multiple hamartomas. And importantly, these patients are at high risk for certain malignancies, including breast, thyroid, and several other things. This is an autosomal dominant gene mutation in the P10 gene. It's a tumor suppressor gene, and it's pretty rare. Incidence is thought to be somewhere on the order of 1 in 200,000, and it has variable expression, so it may be a challenge to make this diagnosis unless you really get a sense of that holistic pattern of all of the features that these patients can manifest. But if you see a patient who has a dysplastic cerebellar gangliocytoma, it's worth initiating a workup for MHAM because of the high risk of having the multiple hamartoma syndrome, and they certainly need to be screened for other malignancies. So what are the pathognomonic criteria that get us to the diagnosis of MHAM? Well, the big things are things that, as radiologists, we don't see unless you're just a very astute mammographer or interventional radiologist that's working very closely with these patients. You probably wouldn't pick up on these things, and those include things like facial trichomomas, acrokeratosis, papillomatous papules, and mucosal lesions. Odds are that's not something that's going to hit our radar. There are several things that are considered as major criteria that as a radiologist you will see and see with frequency. And those include breast cancer, thyroid cancers, especially non-medullary and follicular thyroid cancers, macrocephaly, which may be due to the fact that they have long-standing obstructive hydrocephalus, dysplastic cerebellar gangliocytomas, as our case demonstrated, endometrial carcinoma, and then there's some minor criteria as well, and it's sort of a nebulous grab bag of things that can involve the thyroid in terms of nodules. These patients may have low IQs. They can have GI hamartomas, fibrocystic breast disease, which is something that our mammographers may encounter, as well as lipomas and fibromas. There's also some other genitourinary tumors that have been associated with MHAM as well, a little less defined in terms of whether or not they meet the diagnostic criteria. As far as a little follow-up to this case, this is a nice paper that came from the folks at Mayo, and it was looking specifically at imaging features of dysplastic cerebellar gangliocytoma. And some of the interesting things I think that they've pointed out are that these lesions do in fact oftentimes have enhancement. In their series, over 60% of the time there was some enhancement with it. And that's important because classically these have been presented as non-enhancing lesions. So don't let the contrast enhancement fool you. The other thing that I think is a nice thing that they added in their paper is that these tend to have bright ADC values compared to the normal cerebellum. So again, ADC, we've talked about in other cases of the day, it's a surrogate marker for cellularity. So things that are benign tend to more commonly be bright on ADC. Things that are dark more commonly tend to be malignant. Okay, so let's wrap this up. Dysplastic cerebellar gangliocytomas, things that you need to know as an imager. These are typically unilateral cerebellar masses. For some strange reason, they're more common on the right than on the left. And they have a characteristic appearance of thickened cerebellar gyri. We talked about the terminology that's been thrown at these. Striated, corduroy, tigroid, or gyral pattern of that thickened cerebellar gyri, that bright signal intensity stuff. And again, bright on T2, bright on FLAIR. The paper from Mayo showed nicely that these tend to be bright on ADC as well. And in their series, they found that more than 60% of the time they showed subtle contrast enhancement, just like in this case. A couple pitfalls. If you see a dysplastic cerebellar gangliocytoma, the patient really needs to get worked up for multiple hamartoma or Cowden syndrome, and especially they need to be screened for malignancies because of the high risk of both of those things occurring in this patient population. And again, I want to stress, don't let the contrast enhancement lead you astray. Classically, these have been taught to be non-enhancing lesions, but the newer data and multiple case reports even leading up to that suggest otherwise, that these certainly can have some areas of subtle enhancement. Oftentimes it's curvilinear, a bit wispy. In this case is a pretty good appearance of the kind of contrast enhancement that you may see with a dysplastic cerebellar gangliocytoma. As always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and I would invite you to check out our complete collection of Case of the Day material that can be found on our website at radtf.iuhealth.org/COTD. Thanks so much.